Hello, my name is Bob Mash, and I'm currently the president of the South African Academy of Family Physicians. And we recently published in the Academy a new national position paper on the contribution of family physicians to district health services. The purpose of this presentation is to elaborate on the position that we've taken for family physicians in South Africa, to explain our contribution to strengthening district health services, to correct some misunderstandings that we believe are present in policy on the role of family physicians, to think about a little bit the contribution of family physicians to future national health insurance, and to make recommendations to both the national and the provincial departments of health on the future deployment of family physicians and the training pipeline. So to start off with, just a little bit about the context. So in 2021, we published this analysis of the registered family medicine specialists in South Africa. So just to remind you that a family physician is a specialist in family medicine. They have trained for 4 years to receive a fellowship from the College of Family Physicians and a Master's of Medicine degree in the same way as any other specialist in training in South Africa. And we were recognized as a specialty in 2007. And the data here from 2019 said that at that point, there were 969 specialist family physicians on the HPCSA register. Now, just maybe a little confusing that we also have here medical practitioners in the blue line saying 278. So these medical practitioners are people with some postgraduate training in family medicine who were on the old register prior to 2007 and were not grandfathered onto the new specialist register from 2007 onwards. So on the specialist register, people who are eligible to be employed as family physicians in 2019, there were 969, and we reckon by 2022, as I sit here, there's probably about 1,040 family physicians on the register. You can see that their geographical distribution, as with all specialities, is quite uneven or unequal, with the majority residing in Gauteng and the Western Cape and KwaZulu-Natal. And if one compares the old medical practitioners who remained on the old register with our new specialists on the new register from 2007, you can see that there is some quite considerable transformation in both the age and profile of family physicians. So this slide is showing the number of family physicians per 10,000 population, and you can see again that as I mentioned previously, there is inequality between the provinces. So the Western Cape having the highest number of family physicians per population, and Limpopo the least. You can see in the middle here that the total for the whole country is about 0.16 family physicians per 10,000 population. It's very difficult to get accurate information on the exact numbers in the private versus the public sector, but our best estimate was that about 29% of the family physicians are in the public sector, and the majority, actually 71%, are currently in the private sector. So if we compare these numbers with other countries, so for example, at the bottom here, the United Kingdom, which is of course a high income country, they have around 7 family physicians per 10,000 population. China, I think that was about 1.8 per 10,000 population. Brazil has about 0.2. And as I mentioned, South Africa as a whole, 0.16. But that comes down to even less, of course, in the public sector, which is about 0.05. So relatively speaking, even with other sort of upper middle income countries, and of course with high income countries, South Africa has far fewer family physicians per 10,000 population. So I should say before we go on that there are actually no strict international norms for the number of family physicians per 10,000 population. Of course, the number that you need will depend on the design of your health system. So coming on to some of the public sector human resource issues, this health strategy document was published in March 2020 by the National Department of Health and is currently, I think, the most recent thinking on human resources for health in the country. And we have a couple of issues with this document. The one is how the numbers of specialists have been calculated, particularly for family physicians, of course. And there seems to be something of a bias towards referral hospitals that have led to an under representation of the numbers of family physicians that are needed. And also in its recommendations for the primary healthcare space, that they may only have considered family physicians in terms of the district clinical specialist teams, which again underestimates the number needed for the country. So to show you this in a little bit more detail, the strategy document used a report from Percept to estimate the number of specialists needed. And you can see here that the numbers needed, this is now per 100,000 population, decrease from a high of 5 for anesthetists through all of the other major specialities to family physicians apparently needing the least numbers of family physicians in South Africa compared to these other main specialities. Now, this, of course, doesn't really make sense when you think that family physicians are meant to be working in the district health services and not in the secondary and regional and tertiary hospitals. And of course, that would imply that, in fact, because the district health services are essentially the foundation of the health system, that one would expect the need for family physicians to be far greater than tertiary and regional hospital-based specialities. Whereas the Percept document, of course, has come to the exact opposite conclusion. And I think that this is because they really did the calculations based on the needs of tertiary and regional hospitals. The recommendations in that strategy document around primary healthcare were also largely based on this report that came from the Medical Research Council. And in this document, the need for family medicine specialists was really only considered in terms of their place within district clinical specialist teams. So again, thinking of the family physician as somebody who, in essence, is coming in to a single team at the level of the district, and in this case, having only a focus on maternal and child health. So not considering the need for family physicians actually to be placed within the district health services themselves. So we feel that there may be some misunderstandings about the contribution of family physicians, particularly in the thinking around policy for human resources for health. So coming to the contribution of family physicians to district health services. So of course, the very first thing to say is that we primarily see family physicians working at district hospitals and in primary healthcare. And primary healthcare includes both the primary care facility as well as the community. They are, of course, also deployed, as we know, in district clinical specialist teams. But I think the key point here is that that is not the primary role that we envisage for family physicians, and that is not primarily what we are training them for. So we need to consider their role in the district hospital and within primary healthcare teams. In addition, they are not meant to be deployed at regional or tertiary hospitals, although in some cases they have been. Even some large district hospitals that are organized along sort of regional hospital lines may not be entirely appropriate for family physicians. Furthermore, they are not trained as managers for these facilities, but as clinicians, although in many cases, family physicians have applied for the positions of clinical managers and CEOs in district hospitals and have taken those positions, but that is not what we are primarily training them to do. They are primarily trained as clinicians to work in these spaces. So the contribution of family physicians in district hospitals and in primary healthcare, we can think of it in these three major areas. The one is as a clinician and a consultant to the rest of the healthcare team. The second is as a capacity builder of that team and clinical trainer. And the third is as a leader of clinical governance. And I'm going to just go into each of these in a little bit more detail. So just to remind you that in terms of their training as a clinician, their training goes across these 10 clinical domains, which are very broad across the whole burden of disease, but only for the skills that are appropriate to the district health services. So bringing this skill set into the district health services, of course, enhances the available clinical skills in this level. It means that the expertise available, for example, to manage complicated multimorbidity is increased, and more patients with complicated problems can be managed without referral. This inevitably also improves the comprehensiveness of the services in the district health level. Particularly at the district hospital, the family physician helps now to bridge the skills gap around surgical, anesthetic, and obstetric skills, particularly. And in the primary healthcare space, they often extend the comprehensiveness of services with a focus on disease prevention and also bringing in skills in palliative care. So in these spaces, not only do they provide direct clinical service, but they also act as a consultant to the team in the district hospital. So, for example, this might consist of interns or community service doctors or medical officers, clinical associates, but also to the primary healthcare team, which would typically, in addition, include clinical nurse practitioners, and in the community, of course, also the community health workers. So the family physician then is the most senior clinician in these teams and able to advise and provide help and to supervise the work of others. And as I've mentioned, all of this reduces the need to refer patients to a higher level of care, which saves money and time for both the health system as well as the patients. And a final important role here, and I know a lot of our documents emphasize the need for more person-centered care, and I think this is a particular feature of the training of family physicians in whole person medicine and holistic care, that they can then role model person-centered care to the rest of the clinical team. So in their role as a capacity builder and clinical trainer, all of these teams, of course, need senior clinicians to support them in clinical decision-making and to supervise or even demonstrate procedures. And that is, of course, one of the key roles of the family physicians, to support and supervise the team. In addition, they can provide and do provide clinical teaching in the workplace to the team, or coordinate the provision of continuing professional development to the clinical team. And this of course, is directed at improving the quality of care as well as patient safety. Family physicians are trained in the sort of educational skill set that is needed for teaching and clinical training, particularly in relationship to more formal students and training programs. So the internship, the new 6-month internship in family medicine, makes them a very specific and valuable resource to help train and teach interns and to coordinate their training. And often family physicians in this space are dealing with medical students, with clinical associate students, with registrars in training as family physicians. And as you know, more and more of the pre-service training is happening now on the distributed platform throughout the country, where the family physician has a very important role to play in clinical training. So what we've seen from the research that we've done is not only are they building the capability of the team, but also the confidence of the team to use the skills that they are actually capable of performing. So, for example, in rural district hospitals, medical officers may feel more confident to do surgery because they know the family physician is there to support them and help them should there be any issues. And in the facility as a whole, they are able to start creating a learning environment where the whole clinical team are engaging with critical thinking and learning, and that this cascades down, through the clinical team. And so we've seen this, that the family physician sort of role modeling of being a capacity builder and clinical trainer will be taken up by the medical officers, who will perform a similar function for interns and community service doctors, who may then also perform a similar function for other more junior students. And we know that this kind of supportive, cohesive teamwork is essential to the retention of staff in rural district hospitals and in the district health services as a whole. So finally, we also see them as leaders of clinical governance, and this is all about improving the quality of care and patient safety. So in their training, they are trained in the implementation of clinical guidelines, in leading audit and feedback, in leading morbidity and mortality reviews, on helping the clinical team to reflect on routine data, for example, the use of laboratory investigations or prescriptions. They can also bring skills around assessment of new evidence, and even engage in practical applied research in the clinical space. Another very important element here is the ability to help implement community-orientated primary care, also through clinical governance, because not only do they have this skill set, but also they've been trained in the principles and the approach of community-orientated primary care, which is quite unusual in many of the postgraduate training programs. So not only do they do this in relationship to specific diseases such as HIV or TB or diabetes and so on, but they also can do this in relationship to improve systems for service delivery. So issues around access to care, coordination of care, for example, between primary care and the district hospital, or between district hospital and the next level of expertise, and also continuity of care within the primary healthcare space. So we see their role in corporate governance in terms of the inputs needed for service delivery, such as equipment, supplies, the workforce, health information system, and so on, that they're influencing. So bringing their knowledge of what is needed in service delivery and in the clinical team to the people responsible for the inputs into service delivery. So they can influence, but not fully responsible for corporate governance. They do often have more formal line management, particularly for medical officers and sometimes other members of the clinical team, and engaging in performance appraisal. And of course, a large part of that is also the development of those members of the clinical team. And I think overall, what they are bringing into this space is agency, a thinking about service delivery as a system, and a willingness and an ability to innovate and help the whole team to innovate and to improve in that space. So here is a quote that I came across just very recently from an article published in the South African Family Practice Journal on the impact of a family physician in a rural and remote district hospital. I think this was probably in the Eastern Cape. So family physicians and registrars have been directly involved in re-establishing a regular outreach program supporting primary healthcare facilities, implementing the widespread use of point-of-care ultrasound, driving the growth of surgical and anesthetic capabilities, and in the establishment of a neonatal unit. Their influence has benefited staff by providing a supportive framework to help oppose the roots of systemic burnout, facilitate personal growth through mentoring, and allow opportunities for safe clinical skills advancement. A culture of ongoing quality improvement and research has been established. So I think this very nicely sums up the tremendous contribution that family physicians can make through these three roles. We have done a little bit of research on this across the country, and here the very first bar chart on your left asked the clinical teams working with family physicians and around family physicians in the district health services whether they actually saw an impact of the family physician in these roles that I have described. And in this bar chart, if you're scoring higher than 3, then you're making what they would perceive to be a substantial impact. And as you can see here, across almost all of the roles that I've described, the people working around and alongside the family physicians saw the contribution and rated it quite highly. On the right-hand side, they were also asked, but hang on a minute, is it really the family physician that makes a difference, or could it not just be a grade 3 medical officer or somebody else without this postgraduate training who could, be making the same type of contribution? And here again, if they were scoring 3 or higher, they're telling us that no, it's actually the family physician with that postgraduate training who is bringing the impact across these roles. And we don't think that a medical officer, in the same space would have the same impact. So this is telling us that from the perception of the clinical teams, that the family physician is essential to making the contribution across these roles. Now, it would be very nice to have an in-depth sort of cost effectiveness analysis of family physicians and the sort of return on investment. And maybe in time we will be able to do that. Of course, it's very difficult to tease out the cost effectiveness impact in such a complex system. In other parts of the world, there is, where the big data is available, there is clear evidence that the number of family physicians in the health system is linked to more cost-effective health care and health systems. What we have seen in South Africa, and there's evidence for this, is that family physicians reduce referrals to the next level of care. And of course, that reduces both cost for the patient and for the health system, because care that's delivered in the district health service space is cheaper, essentially, than care that's delivered at tertiary or regional hospitals. They can reduce the number of repeat visits because people can be diagnosed more effectively and don't have to return continuously until the diagnosis and correct treatment is made. They can help coordinate care and reduce duplication of both activities and things like laboratory investigations, and help the teams essentially to use resources more efficiently. I think one aspect that we often forget about is that most of our provinces are facing quite enormous litigation, and medical legal costs are actually quite enormous. And the family physician, by improving the quality of care, can either reduce the amount of litigation or make such cases defendable. And this is certainly, as was reported to me, I think from the Eastern Cape just a few weeks ago, that that many of the medical legal litigation is around maternal health issues, and that the cases that have been defendable have been the cases from district hospitals with family physicians. And of course, this cost runs into multi-millions of rand. The implications for national health insurance. So as you know, this is an emerging policy, and there's many things that we don't know yet. And it's going to be progressively rolled out over the next few years. But it's very clear from what I've said already that family physicians can make a huge contribution to the quality of care, patient safety, and the essential core functions of primary care and in district hospitals. And having sufficient quality is a prerequisite, I think, for the acceptability of NHI in the population. We feel that the policy should have some mention of family physicians in its service design and its discussion of the workforce, that the contracting units for primary healthcare should certainly consider what is the role of the family physician in those contracting units, and in who is contracted with. And NHI should also, as is now in the public sector, ensure that family physicians are remunerated as specialists. And we should look at incentivizing medical officers and general practitioners as they are brought into the health system under NHI to even if they don't become family physicians, to reorientate and upskill themselves through things like the diploma in family medicine. So that is the contribution that we see family physicians making to the district health services. And then what then is the need that we see? So we have set a very practical and I think feasible midterm goal, and by that I mean over the next 10 years, of one family physician at every district hospital, every community health center, and every sub-district which doesn't have a community health center in the country. So this is, I should say, a midterm goal, so it's not the end point. And in fact, in some of these situations, for example, many district hospitals would actually benefit from more than one family physician. And we already see this in the Western Cape, where, for example, maybe the one family physician focuses more on supporting the primary healthcare platform and the other more on supporting the services within the hospital, but of course, both working across the whole space. And if we look at this goal, we would need 680 family physicians in the public sector to achieve that, based on this information of 254 district hospitals, 321 community health centers, and 104 sub-districts without community health centers. And that data may have shifted slightly, but I think in essence is correct. And that means that we currently have a gap of 400 family physicians that we would need to fill in the public sector in order to achieve this midterm goal. So the current supply of family physicians in the country, we currently take in about 50 new registrars per year across all 9 training programs, although I have to say that those numbers have decreased in the last 2 years as many provinces have reduced the number of registrar posts. But on average, say over the last 5+ years, we've had an intake of around 50. The output after 4 years has been around 27 new family physicians per year graduating. And of those 27 family physicians, we estimate that 42% are retained in the public sector, which is 11, 48% enter the private sector, which is 13, and about 10% emigrate within the first few years, which is 3. So if you then have a look at playing around with some of these factors, the numbers entering the training programs, the throughput of the training programs, so the numbers graduating, from the training programs, and then the numbers retained in the public sector. At present, that's the first line in red. At our present situation, it would take 35 years for us to fill that gap of 400 family physicians. And then as one plays around with these numbers, one of the more feasible options is this one at the end here, which would require us to double the number of registrars entering the training programs per year to increase the throughput. So the training programs have to do a bit of work to increase their throughput from 54 to 70%. And then the provinces need to do their job to retain family physicians in the public sector. And that would probably mean creating 4 to 5 posts per year on average to fill the gap. But this would allow us, if we had 60% retention in the public sector, to fill that gap over a 10-year period. So practically, as I've said, what this means is we need to increase the availability of registrar posts by a factor of 2 on average across the country for the training programs. And of course, these posts, I think, are largely decided by the provincial departments of health. The family medicine training programs need to ensure a throughput of 70%. And then again, the provinces need to look at creating and retaining family physicians in the public sector. So on average, and of course this would need to vary between provinces based a bit on the current inequalities, but on average, this would mean 4 to 5 posts being created per province per year for 10 years to achieve this midterm goal. So that is how we see our contribution and what we think is needed in order to maximize our contribution and to strengthen district health services over the next 10 years. And I thank you for your attention.